Thank you so much for joining tonight's presentation on individualizing diabetes care for Black Canadians, South Asian Canadians, and those fasting during Ramadan. My name is James Kim. I'm a general practitioner working in Calgary with a special interest in chronic diseases, especially in diabetes. Tonight we have Dr. Akshay Jain to present on this very, very, very interesting, very prevalent and relevant topic in our care. And it's kind of interesting to see that two immigrants, one's moderating, one's presenting on this topic that is really, really important. So I'm actually from Korea originally, but grew up in Africa. So this topic is actually really relevant to me, especially the fact that I work in the area where there's a lot of foreigners, a lot of people from various parts of the world in Calgary. I just want to remind all of you to please type in all your questions in the Q&A box, and we'll answer the questions at the end of the presentations. If you have any questions regarding the technical issues, then please do type in your Q&A and we'll address that. Also, just would like to thank Jansen for sponsoring this event, and also Salient Communications for making this possible, and for platform production team with the IT support as well. So tonight we have Dr. Akshay Jain. He is an endocrinologist, sorry, maybe I should say superstar endocrinologist from BC, with a special interest in mainly diabetes and other metabolic conditions. I will put his full bio on the chat box, so please do check it out. His mini bio is not really that mini anymore. It's actually pretty impressive. So please do feel free to check it out. Without further ado, Dr. Jain, please take over.
Thank you so much, Dr. Kim, and a very good afternoon / evening to all of you logging in today for today's accredited webinar. So this program has been accredited for OneMain Pro Credit, and I'm very glad to be able to share a topic that is very close to my heart. The program that we're about to show today, I've been very fortunate to be on the panel or the planning committee with some very, very well-known names in the field of diabetes across Canada. You'll recognize most, if not all, of these wonderful, prestigious names here on the panel. These are my personal disclosures. And as Dr. Kim mentioned, this program was made possible by a grant from Janssen Canada, whose products will be part of the included products that are discussed today. And the mitigation of bias is made possible by ensuring a very stringent evidence-based literature search that we are sharing with you. So all the data that we are sharing is all evidence-based information. And of course, as we discussed, this is an accredited program, so it has been through the rigors of ethical review as well. Our learning objectives are basically illustrated on this slide here. We will be talking essentially about how there is nuances in the management of diabetes when it comes to addressing particular aspects of diabetes in visible minorities, including in Black Canadians, South Asian Canadians, or Muslim Canadians who are fasting or plan on fasting during Ramadan. And we will look at the current Diabetes Canada guidelines, as well as guidelines from across the world in the latest evidence that is currently out there that can help clinicians like you and I make decisions for the benefit of our patients. It will be, in 2 months from now, it will be 8 years since I made one of the best decisions in my life. I moved to Canada 8 years ago. And whether you were born in this wonderful country or you were fortunate to immigrate here, just like Dr. Kim and I, the one thing that all of us are only too aware about is how wonderful the inclusion is in this country. Canada welcomes people from all different walks of life, from all different ethnic, cultural, demographic backgrounds, which is what makes this country so very unique. And having said that, it is wonderful to note that immigration into Canada is currently one of the strongest that it has been in many decades. But as clinicians, what this implies is that you and I, as healthcare providers, need to be even more cognizant of a bigger variety of cultural nuances, patients' background beliefs, and their diets, as well as their pathophysiologies when it comes to management of many of these medical conditions. And all of us, we are constantly learning in this field of medicine. You'll see on the slide here that it is thought that the number of Canadians who identify as being from visible minority might go up to more than 1/3 in the next few years. And especially in the next generation, we are seeing even more number of kids with an immigrant background there. So it's only bound to go up higher. And the three population groups here, which have the largest representation in the visible minority groups, are South Asians, Chinese Canadians, and Black Canadians. So it's really important that we are very aware about various pathophysiological and cultural aspects of our patients, especially when you look at diabetes as a chronic condition. This has so many ramifications in our patients from diverse backgrounds. Diabetes, we know, is way more prevalent in patients from visible minorities. To give you an example, currently in Canada, the prevalence of diabetes is between 9 to 11%. So 9 to 11% of Canadian adults will have been diagnosed with diabetes. Whereas if you look at the same number, but then you look at South Asian Canadians, that prevalence is anywhere between 19 to 26%. So that's a very high number. And what's interesting to see is not only is the prevalence higher of diabetes, but the incidence of complications of diabetes is much, much higher. And unfortunately, in these high-risk populations, there is reduced screening for complications as well as lab monitoring because of a plethora of different socioeconomic reasons. Uh, and it's very important to note that the current literature suggests that even when corrected for these socioeconomic reasons, for insurance coverage or the lack thereof, age of the patients and comorbid conditions as well, despite correction for all of this, across all chronic conditions, there is a much lower quality of healthcare that is being delivered to these Canadians. So it's really something that we have to work on an ongoing basis, regardless of whatever our current, background of practice is, in a rural setting, suburban, urban setting, hospital, or outpatient setting. We really need to work on improving the quality of care and access in these visible minorities. And how do we do that? I think the first step starts from introspection. We really need to be aware about the issues surrounding the diabetes, because diabetes, of course, is not a condition just with dysglycemia. Along with poorly controlled blood sugars, there can be many different things that come into play, including increased cardiovascular risk, increased renal risk, increased risk of depression, so mental health, mechanical problems like limb issues. So all of these need to be taken into account. And what's very important to note that we cannot club all immigrant population into one big group, because there's so much difference, there's so much diversity in these patient populations that we have to look at these backgrounds with a magnifying glass and be aware of what each individual cultural practices are and how these circumstances can affect the care that is being given, as well as how they incorporate this care into their day-to-day life. And more importantly, the key with diabetes management is, regardless of the background or for whatever reason that you're looking at, we really need to individualize the care, whether it's pharmacotherapy, whether it's diet, whether it's glucose monitoring. All of these things need to be individualized for our patient. And that's really the key. If there's only one thing that you can take away from my talk today, it would be that recognizing, of course, that each patient is very different, and trying to put ourselves in our patient's shoes so that we can overcome what's the biggest challenge from our patient's perspective, rather than what we feel should be their priority. Today, I would like to walk you through three different stories. So three different Canadians with three unique stories. We've got Robert, Ashwin, and Reem, and we'll talk about how diabetes has been playing a part in their lives and how we can help them out as healthcare providers. So Robert, a 58-year-old male who has been living with type 2 diabetes for 12 years. He is a new patient in your practice, has not seen any healthcare provider in over a year, and immigrated to Canada over 15 years ago from Jamaica. His current medications include metformin 500 BID, telmisartan 80 milligrams, and atorvastatin 20 milligrams. You'll notice his BMI is on the higher side here, and blood pressure is above target range of 130/80, target that we use for most of our patients with diabetes. Along with those factors, you'll see from the labs, his A1C 7.8%, GFR 43. He has macroalbuminuria with ACR of 34. And luckily, his LDL is at target of less than 1.7. Looking at his chart, the one thing that you see, of course, is that he has been lost to healthcare. But more importantly, he tells you that he's very frustrated with his experiences in the past. He found that his previous doctor had blamed him for his diabetes, and the doctor couldn't understand Robert's accent. Robert felt that his doctor would keep wanting to give him more medications, and he was also discharged from his nephrologist. And the one thing that you see plastered over all his chart is the word non-adherent and non-compliant. It's been plastered everywhere. So with that review of his chart and with that background knowledge, I would request you to look at the poll question that comes up on your screen here. So given that information based on Robert's case, what would your focus be at this meet and greet meeting? Would you want to address his non-adherence, which has been plastered in his chart all places? Would you want to address his A1C, blood pressure, his dwindling renal function, or would you want to engage him in a discussion about his diabetes? So I would request you to use your computers to put in the answer that you feel would be the most appropriate. None of them are wrong, of course, but what you feel would be most appropriate. So we'll wait for a majority of people to get a chance to key in their answers. And sharing this here, 71% of us feel that we'd want to engage the patient in a discussion about his diabetes. And like I said, there's no wrong answers, but I would certainly agree with option E here, which is engaging the patient in a discussion about his diabetes as the first step ahead. Why is that? So let's talk a little bit more about this current scenario. For us, when we see Robert, and you'll see on the right-hand side of the screen here, our tunnel vision here focuses just on his diabetes, right? Just on his blood sugars and the ramifications of his diabetes. And rightfully so, because we are, of course, worried about the complications of diabetes. But that does not define Robert. Robert is not a diabetic. He is a person with diabetes. And there is a big difference between the two. Because if he is diabetic, then that probably becomes what defines him. But he's a person with diabetes, which means that diabetes forms just one small aspect of his entire life. He's got so many other things to think of, his family, his job, everything else. And that diabetes, that speck in that horizon may or may not be that important for him. So we really have to be mindful of what his challenges are and whether or not this diabetes part, if we can increase that priority and help him address his diabetes. It's very important to note, of course, that most of the decisions made by people with diabetes happen outside the healthcare setting. Obviously, if my patient is getting a low blood sugar while he's out and about, then they would want to correct that without first wanting to touch base with their doctor or the healthcare provider. At the same time, if my patient goes out to a birthday party and they are trying to figure out whether they need to, what would be their dietary intake at that party, that's a decision they have to make right then and there. So all these daily decisions, they are made 24/7, and that's something that the patients need to make on an ongoing basis. So we really can't decide for them, because otherwise we take away the autonomy from our patients. And that's where self-management education becomes very, very crucial. We empower our patients, we put them in the driver's seat so that they can make those decisions. You give a man a fish and he's not hungry for 4 hours, but if you teach him how to fish, then he is not hungry for the rest of his life. So empowering the patient becomes very, very crucial. And this, of course, has to be done in a collaborative manner, trying to find out what is their important, what their priorities are, and how we can help shape them, and also help discuss what our priorities are as well. Now, it's important to note that racism, whether we admit to it or not, unfortunately, in healthcare setting is quite too prevalent. And it's a wordy definition here, but it's important to note that the disparities seen between Black people and other ethnicities with respect to medical conditions and the risk factors are not explained by biological differences between races. In other words, we cannot, for the most part, just blame a certain condition or certain complications just as a biological difference between races, but it's primarily because a lot of it deals with the healthcare system, the access, as well as the healthcare that is being given to our patients. So there's two types of bias, and I want to take the next few minutes just to go over this, and I think it's a really, really important point. There's the explicit bias, which is knowing when someone is having a prejudiced, a judgment against other people based on whatever stereotypes they know of. But what is more prevalent, perhaps so, is implicit bias, which is we have a certain attitude towards people different from ourselves without knowing that we are having that prejudice. So this is what the implicit bias is, and it becomes really important to note because at a certain level, some of us may be having an implicit bias that we are obviously not aware about. And the whole idea is that we cannot keep perpetuating the stigma and bias because for us, it is just that one patient, but for that patient, it is every healthcare provider that they've ever met as inherently being biased in one way or the other. And this is something that drives their experience regarding the healthcare system. It's very crucial that we use non-judgmental language and avoid patient shaming. But of course, very crucial that we collaborate with them and put them in the driver's seat. It's really important because words can make a very, very big difference. You'll see here where this patient is in front of a physician who's obviously worried about his diabetes, but the physician, look at what he's saying. You don't seem to want to eat better to get your diabetes under control. This is easy. Why aren't you doing this? So this might be an inherent level of bias. The physician, of course, is watching out for the patient, but the way this is communicated is not really the best, and that can create a big hurdle in the overall healthcare delivery. Implicit bias is something that has been studied predominantly across many different clinical settings. And in your chat box here, we'll be putting a link where I would strongly encourage, maybe at the end of our talk today, you take this test. It's called the Harvard Implicit Bias Test. And you'd be surprised at what your level of implicit bias could be as well. So a very fun activity to do maybe at the end of the CME. Okay, let's look at implicit bias, and I'm going to give you a patient's example. So this is actually a very nice study that was published a few years ago, and this basically gives the example of, say, a patient who has come in with hypertension. So this is a Black Canadian patient coming in with hypertension who is already on blood pressure medications, despite which their blood pressure is not at target. Let's look at how bias can affect healthcare. When you look at it from the clinician's perspective, the clinician may have some degree of implicit bias, which may be based on his or her clinical as well as non-clinical experiences with people that are different from the clinician themselves. So this forms an inherent background experience that the clinician has inherently imbibed. And this in turn can affect their behavior and judgment significantly. So in this example in the paper, they suggested that a clinician, a white clinician, saw a Black Canadian patient with poorly controlled hypertension. And seeing the chart, so suggesting that the patient is non-adherent, automatically assume that the patient continues to be non-adherent to their medication without asking the patient. In fact, the clinician asked the patient, how many times a month do you forget you take your blood pressure medications? The patient said maybe 2 times. And the physician said 2 times equals maybe 15 times. So they just said that the patient is not being adherent. Also, in the same example, the physician erroneously thought that the patient cannot afford their medication because of whatever implicit bias that there might be. So they just decided to go with a certain part of pharmacotherapy, not wanting to explore other pharmacotherapy options. And because of all of these, at the end of the patient encounter, medication intensification was not done. Rather, the only discussion was done about medication adherence and telling the patient to make sure that they come to their next appointment so that we can see if their blood pressure is well controlled or not. So you can see how that bias has caused this vital step, the medication intensification, to go wrong, and the patient continues to have high blood pressure that is not well controlled. Now, let's switch gears. Let's look at the patient's perspective. This is a patient who has been to many doctors, just like Robert has, where previously doctors have accused him of not taking his medications regularly, have, for whatever reason, given him medications that may or may not be something that he's looking for. And all of these background experiences have shaped his experience with previous clinical encounters and what his perception of the clinicians is. And when the patient feels that the clinician is not on their side, they are very less likely to be adherent with their clinical plan. And that drives this vicious cycle where the patient does not have trust, does not want to adhere to the regimen, and the clinician feels that the patient is not adhering to the regimen and hence does not want to escalate therapy. So it's really that this vicious cycle that needs to be broken at every possible instance. How do we do that? Most importantly, we can continue to confirm with the egalitarian goals that form the fabric of this wonderful country, making sure that we realize that everyone is equal and we look at it from that perspective, even when we are seeing each patient. So suppressing those implicit biases becomes very important. Gut reaction, interestingly, gut reaction, we are told to go with our gut reaction in medicine, but gut reaction is just another word for implicit bias. And this is something that we need to look at. Introspection for this gut reaction becomes really important. And that's when you do the Harvard implicit test, like we discussed. It will show you how it may affect your work. Always make sure that you are considering the situation from the patient's perspective. If there's just a second thing that you could take away from my talk, it would be this, that no patient wants to be unhealthy, right? There's not a single one of us, whether even when we have been patients, that we want to be unhealthy. So of course we want our health to improve and we would want to adhere with whatever the regimen is. But if our clinician sees that the patient is not being adherent, then try to find out what's the challenge there. What is the patient's perspective and work on that particular aspect. Making sure that we refrain from the stereotypical responses, because this is something the patient has seen day in and day out, whether it's related to their race or their physical appearance, obesity, so many different aspects. It's really important to shy away from those stereotypical responses and looking at each patient as an individual. So how do we do that? Let's take Robert's case again. And when you have a physician who's on Robert's side, here's what she may say. Robert, I'm glad that you came in to see me. So this is re-emphasizing that, that's helping improve that patient adherence with the visit adherence. I can see a few things that I would like to discuss about your diabetes, but what is the most important thing for you? What are your goals for diabetes? And this is the first time when Robert has felt validated, because as an individual, he's been asked about what his priorities are. And he shares that his wife is worried about his diabetes and kidneys. And he knows that the kidney function is getting worse and I have to do something about it, but I can't come in every month for a visit because of work. I can't take time away. So the doctor then understands and is agreeable to working with him. I think we can work together to better manage your diabetes. I want to change some things around to help you reach your goals. And knowing this in background, let's see how we can work. So when you come to kidney function, this is the KDIGO guidelines. So the National Kidney Diabetes Foundation guidelines. We know that Black patients have, unfortunately, a much higher rate of microvascular complications as well as mortality compared to white patients. In fact, Black patients have a 3 times higher likelihood of kidney failure. And the primary reason for this is diabetes. So all our patients, in order to improve their kidney function, we need to look at the ABCs of diabetes, so A1C, blood pressure, and cholesterol, as well as the DES, where we look at the diet, exercise, and smoking cessation. So this becomes really crucial for all patients with diabetes. Then, in patients with microalbuminuria or those with macroalbuminuria, with dwindling renal function, with poorly controlled diabetes, we look at adding RAS blockade, ACE inhibitors or ARBs, as well as SGLT2 inhibitors. And then for some patients, for secondary prevention especially, we want to consider antiplatelet therapy. So this becomes really important for cardiorenal protection. And this is where the latest Diabetes Canada guidelines have done a remarkable job. So if you see that if the patient is not at A1C target, or if they have developed atherosclerotic vascular disease, so heart attack or stroke, chronic kidney disease, or heart failure, or risk factors for complications of diabetes, cardiovascular risk factors, and we'll focus especially on the chronic disease, chronic kidney disease part, like Robert is. The current guidelines recommend that regardless of the A1C, we should be looking at an SGLT2 in the CKD patients to reduce the risk of MACE, which is major adverse cardiovascular events, reduce the risk of hospitalization for heart failure, as well as reducing the risk for progression to nephropathy. So SGLT2s have the strongest evidence for diabetes patients with CKD, regardless of the A1C. This becomes really important. More importantly also is that in Black patients, the prevalence of hypertension is much higher and hence a higher risk of stroke. It's important to note that calcium channel blockers are wonderful, effective treatment options in Black patients with hypertension. And although these agents are really good at blood pressure control, we still have to continue to use ACE inhibitors or ARBs because still they're very important for cardiorenal protection for patients with diabetes, right? So ACE inhibitors continue to be very important. And for hypertension, you can consider the use of non-hydrodipyrimidine, the calcium channel blockers there. From that perspective, let's go back to Robert. Robert is asking for a simplified regimen. You want to add an SGLT2 inhibitor. And the good news is, regardless of whatever SGLT2 inhibitor you choose, whether it's dapagliflozin for Zika, empagliflozin, Jardiance, or canagliflozin, Invokana, they do come in a combination with metformin. So a fixed dose combination helps to reduce the pill burden for our patients. And we know that SGLT2s can cause a slight drop in the systolic blood pressure by about 3 to 4 millimeters of mercury. So once that is initiated, we look at the blood pressure, and if the blood pressure is still high, which is likely because Robert's starting blood pressure is 145/86, then maybe we can change telmisartan to a combination telmisartan amlodipine so that we can further get to the target blood pressure range. And very important, Robert can't take time off from work to come in for his appointments. So this is where we can do virtual appointments, right? So we can just touch base with him on the phone, see how he's doing. He can get his blood pressure checked at his local pharmacy and can still do his lab. So this helps solidify the doctor-patient relationship over there, and then take it forward by prioritizing Robert's diabetes priorities over there. Okay, so with that, I'm going to switch gears and we're going to talk about a second story. Our friend here, Ashwin, is a 67-year-old male with type 2 diabetes for 17 years. 3 years ago, he had a heart attack. Luckily, though, his ejection fraction is not reduced. His LVF is 65%. He's on metformin full dose, sitagliptin or Januvia 100 milligrams daily, perindopril 8, bisoprolol 5, rosuvastatin 20, and aspirin 81. So the usual laundry list that you could anticipate in a patient with heart disease and diabetes. If you look at his assessment, his BMI is 24, so it doesn't sound too bad. Blood pressure 128/68, so that's in target. A1C 6.5%, that's in target. GFR is 68, and his LDL is also at goal. So at the face of it, this is a patient that I love to have, in the middle of my day, because from what it looks like, everything looks really good. So this is a patient where I can pat them on the back, say, everything's looking good, I'll see you soon. And that short appointment can then help me save some time and catch up on my day where I'm already falling behind. Or is that the case? So in your in your practice, if you see a patient like Ashwin, what would you want to do? Would you do nothing because he's a target? Would you want to stop sitagliptin and instead use an GLP-1 agent? Or would you want to add an SGLT2 inhibitor? Or would you want to perhaps add a sulfonylurea? So please take a minute and answer the poll question on your screen here. Good. We've seen almost everyone answer this. So we will close the poll and we can share the results here. So 61% of you have said adding an SGLT2, 33% saying stop sitagliptin and start GLP-1. So that's fantastic because collectively more than 90% of us have selected a right answer. And no one has selected sulfonylurea. So that's fantastic. So let's talk a little bit more about Ashwin. Ashwin, South Asian patient, here you'll see that after his MI, he's dramatically changed his lifestyle. He has now started taking his medications more seriously, is exercising on a regular basis. But the challenge is his diet. When he was discharged from the hospital, he was given the regular Canada food guide and asked to take more protein, but the protein options in there were steak, which he does not have because he is vegetarian. He was asked to increase the amount of fish in his diet, which of course he cannot have as well. And the vegetarian options included tofu or quinoa, both of which he does not like because they don't form a part of his usual South Asian diet. So because he was not given culturally specific dietary recommendations, he does not know what to do. What can he eat? What he cannot eat? And this is something that's really affecting him because on a day-to-day basis, this is affecting his quality of life significantly. He's very committed. He wants to make sure he does not get another cardiovascular event. And with this is, this is the background information that he comes to you with. It's really important to note that being South Asian has a significantly higher risk of cardiovascular disease. So we know that South Asian patients have a much higher risk of premature coronary artery disease. And this cannot be explained by traditional risk factors alone. In fact, a very, very big correlation is with the abdominal obesity. So we know that South Asians tend to have much higher degree of visceral adiposity compared to other ethnicities. And this in turn drives up the insulin resistance, which is why now they are recommending that we need to have ethnic specific BMI and waist circumference cutoffs. Let's take a look at this example here on the right-hand side in this table. You'll see that even a BMI of 23 to 25 is considered overweight in someone who's of South Asian or East Asian ethnicity. So what others or Caucasian ethnicities would be classifying as normal would be considered overweight. And that's why the current guidelines also recommend that screening for diabetes should happen if a BMI is more than 25 for Caucasians, but that BMI cutoff is 23 if the patient is Southeast Asian, South Asian, or East Asian in ethnicity. And this is a very important aspect because of this population's inherently increased cardiovascular risk. Now, it's important to note that currently Framingham risk, which is what we generally use to risk stratify patients, does a very poor job for South Asians. Reason being, the Framingham risk calculator was based on data in Framingham, which is a town in Connecticut, which is essentially comprised of a majority of Caucasian town dwellers. And that does not have too many South Asians in it. So that's the challenge. But a few years ago, researchers in the United Kingdom came together and developed the Q-Risk3 calculator. This is a fantastic calculator that I would suggest putting as a bookmark. I certainly have a bookmark on my Internet Explorer for doing that for all my South Asian patients, because this also looks at ethnicity, including patients of South Asian descent. So when you look at this link here, you'll see that there's multiple factors that you can check off for, including ethnicity here that you can identify for the patient. Now, let me give you a real life example. Say, for instance, I have a 64-year-old male who's Caucasian, light smoker with type 2 diabetes, who has premature history of family history of premature coronary artery disease, the patient himself has CKD stage 3 and is on blood pressure treatment with a systolic blood pressure of 134, and their BMI is mentioned here. For this Caucasian patient, their cardiovascular risk in the next 10 years is thought to be 49.6%. Now, the only thing I'm going to change here is changing that Caucasian to Indian, and the risk goes up from 49% to 59.5% just by changing the ethnicity. So the same patient with the same demographics, their risk would be much lower for Caucasian and much higher if they're of South Asian origin. So this really helps put that in perspective and get a more realistic risk of what our patient's cardiovascular overall profile would be. And the reason is because South Asians tend to have a phenotype that is called the Indian phenotype, what is colloquially referred to as a thin fat Indian. But basically what it generally means is that patients of South Asian ethnicity tend to have more insulin resistance, higher levels of inflammation or inflammatory markers, and they generally tend to gain weight in the belly region here. So they generally tend to have higher waist circumference for the same BMI, and their dyslipidemia is very characteristic. It is basically shown with high triglycerides, low HDL, and their small dense LDL is also very high, which puts them at a very high risk for cardiovascular disease, and inherently this population is at a higher risk for diabetes, to the point that 8 out of 10 patients in India currently have at least one feature of that Indian phenotype. So this becomes really, really important. And the Diabetes UK, which is the British counterpart of Diabetes Canada, of course, they've got billions of South Asians living in the United Kingdom. They have seen that this patient population, they've been looking at it very closely, and they've come up with guidelines for the management of diabetes in the South Asian population. So I would strongly recommend you to take a look at it in your leisure, because this is a very good guideline. And they do say that in the South Asian diet, there's increased carbohydrate intake, there's reduced fruit and vegetable intake, and less physical activity, which puts these patients at a higher risk for diabetes. And in fact, the UK data suggests that what is a 30 BMI risk for a white man would be approximately the same risk for a BMI 22.6 in a South Asian man. So you'll see that the stark difference in the BMI and the waist circumference that correlates to a risk at 102 centimeters in white men is roughly equivalent for South Asian men at a much lower threshold for 83.8 centimeters. So it's really important to note that the ethnicity and the visceral adiposity associated with it increases the risk for cardiovascular disease and diabetes. And this is seen in both micro and macrovascular complications of diabetes. Cardiovascular disease, 40% higher, coronary artery disease, 35% higher in South Asians. Stroke risk is almost double, microalbuminuria risk, 14% higher, and retinopathy occurs at a younger age and is much more severe. Now, just as a side topic, also, we generally tend to focus a lot on A1C as a marker of glycemic control. But herein lies the problem, because we do know that there's a lot of hemoglobin variants. For instance, 6 to 9% of Black individuals may have sickle cell variation, so hemoglobin S. There's hemoglobin C as well in some Black individuals. And then if you look at Southeast Asians, hemoglobin E tends to be very high, up to 30% in the South Asian and Southeast Asian populations. And all these different types of hemoglobins can sometimes cause false A1C levels. Now, in Canada, most of the labs use immunoassay method for checking A1C. There's 4 different types of checking A1C. There's 4 different methods of checking A1C. One is the immunoassay type. The second one is the boronate affinity type. The third one would be the HPLC or chromatography type. And then the fourth one is enzymatic type. Across Canada, most labs are using the immunoassay lab, which mitigates that hemoglobin E variation. So you don't have to worry about hemoglobin E, because the immunoassay lab can take care of that and gives you a precise A1C. Some labs, however, still use the HPLC method. So it would be a good idea to find out. And what my clinical takeaway from this would be that if you have a patient where their home blood sugar readings do not match up with their A1C, It's always a good idea to consider either hemoglobinophoresis to see what hemoglobin variant that they have. And if it's a problem, you can consider using fructosamine as an alternate method of glycemic control, or you can use CGMs because most of those sensors, whether it's flash glucose or real-time continuous glucose monitoring, will also give you an estimated A1C. So that's very helpful. Now, in South Asian patients, when you're looking at diabetes and their high cardiovascular risk, here are the considerations. So if you're looking at metformin, that still continues to be gold standard as first-line therapy. However, metformin can drive B12 deficiency, and many South Asian patients may be vegetarian, so it's a double whammy for them. GLP-1 therapy has both effects on the CV outcomes as well as effects on weight. So it helps reduce that visceral adiposity and also helps control postprandial blood sugars, which is a big challenge in carbohydrate heavy diets. Also, SGLT2 inhibitors in this population can have very good effect with the weight, the cardiovascular and renal outcomes. And also, because the SGLT2 works through the kidney and not from the insulin pathway, not from the pancreatic pathway, this gives another way of reducing blood sugars and not being very pancreas dependent. So when you have patients from these different cultural backgrounds, it's important to find out whether language barrier is playing a role. Many times the patients may not admit that they are unable to understand English very proficiently. So always a good idea to get an interpreter or a family member in, making sure that we're doing frequent follow-ups, and very important to have diet and lifestyle knowledge. There's some fantastic diet resources from Diabetes India that we're going to share with you in the chat box here. And I share this with all my South Asian patients because it helps them decide what kind of diet they want to incorporate, which is more culturally very relevant for them. And most importantly, just like with Robert, with Ashwin as well, we want to make sure that he feels that he is in control of his diabetes. When you look at the latest Canadian Diabetes Canada guidelines, again, you look at patients with ASCVD, CKD, or heart failure. For Ashwin, who has pre-existing atherosclerotic vascular disease, regardless of his A1C, we want to use a GLP-1 or an SGLT2 so that we reduce MACE events. And that's why 90% of you got the answer right on the button there. And if you want to further reduce hospitalization for heart failure or nephropathy, SGLT2s have grade B evidence for that patient population. So for this patient, despite their A1C being in target because they have ASCVD, I would like to change the patient from a DPP4 instead to a GLP-1 or consider an SGLT2. We could even do both. Both of the GLP-1 and SGLT2 can be used in conjunction as well if you want better glycemic control or more weight loss for patients with diabetes. May not be applicable for our patient here. Finally, let's go to Reem and let's learn about her story. Reem is a Muslim Canadian, 59 years old with type 2 diabetes for 7 years, no history of cardiovascular disease or CKD. On extended release metformin, Glumetza, full dose, gliclazide MR, full dose, linagliptin, Tradjenta, 5 milligrams, atorvastatin 20, and candesartan 8 milligrams. BMI is 26, blood pressure seems to be at target, A1C 7.1%, GFR 78, LDL 1.5. Microalbuminuria is not mentioned here, but for the sake of discussion, let's say the microalbuminuria is not elevated for Reem. Now, looking at Reem's case here, what would you recommend? Because Reem has come to you 2 months before Ramadan, and she says that she wants to go fasting during Ramadan. So would you tell her that no, there's absolutely no way you should not be fasting during Ramadan? Would you want to reduce the dose of her metformin, stop the gliclazide, perhaps add an SGLT2? Would you want to stop the Tradjenta, linagliptin, and start a GLP-1? Or just say everything looks good, you're okay to fast during Ramadan? So none of these are potentially, all of these options could have some degree of truth in it, but what would you feel is the most appropriate option? So the poll is open on your screen here. Good, and in the interest of time, we'll end the poll and share the results here. So majority of you said we will be stopping the gliclazide, which is fantastic. That is certainly something that I would strongly recommend, but let's take a little bit more, let's take a look more at Reem and what the guidelines recommend. So interestingly, a few months ago, the Diabetes and Ramadan Practical Guidelines came out. So there's extensive guidelines for help treating patients who have diabetes and plan on fasting during Ramadan. We are sharing the link with you for this 330-page guideline with you. Now it's 330 pages. It's very comprehensive, but you're in luck because I will be discussing the key aspects of these guidelines with you in the next 10 minutes. Basically, we look at risk stratification and making sure that we're doing the assessment well ahead of time, what the implications are for type 1 as well as type 2 diabetes, as well as special populations. Now, let's take a step back here. Ramadan basically falls in the 9th month of the lunar calendar, not the Gregorian calendar. So every year it can be on a different day. And depending on when it happens, if it's in the summer months, in Canada especially, the daylight hours can be very long. Now, why is this significant? Because all Muslims that fast for Ramadan will not eat or drink anything during daylight hours, right? So all of that is refrained from during daylight hours. And this is applicable for all Muslims that are beyond the age of puberty. And generally, the first meal of the day would be at sunset. So as soon as the sun sets, that's the biggest meal of the day, iftar. And then patients may eat smaller meals throughout the night. And the last meal would basically be before the sun rises in the sky, called suhoor, which is the meal before pre-dawn. So these are the two meals, the two big meals. And then important to note, the patient will not eat or drink anything during daylight hours. Now, it's important to note that not all Muslims fast during Ramadan, but a majority of them, even if they have type 2 diabetes, may fast during Ramadan. Another important point to note is that those who are fasting during Ramadan do not necessarily fast for all 30 days. So there may be some days when they are fasting and some days when they are not fasting, but majority of people will do at least 15 days or more of fasting, even if they have type 2 diabetes. And almost 2/3 will complete 30 days, so they'll fast throughout the whole month. And what's very important to note that some patients may still need to break their fast because of low or high blood sugars. And this is very crucial because patients may not know this. It's really important that we tell them that if they are running very high or very low, it is okay to break the fast. If the sugars are very high, they're at risk for diabetic ketoacidosis. So it's important to drink water and control their blood sugars also. And if their blood sugars are very low, of course, then it's important to correct that hypoglycemia. Unfortunately, less than 1/3 of us are actively asking our Muslim patients whether or not they are fasting or plan on fasting during Ramadan. And unfortunately, many of us are still not comfortable managing our patients with what do we guide them about Ramadan fasting. So the key is to start early, making sure that we're bringing in our patients with plenty of time to spare, at which point of time we can quantify their risk, talk to them about glucose monitoring, when should they break the fast, when to exercise or what kind of exercise, what kind of foods to eat, and how do we adjust their medications. Now, in the guidelines that we have just shared, there's a very cool risk calculation tool, and it gives you, I'm just gonna magnify this here. So it gives you different aspects over here, which helps you calculate the risk for the patient. And depending on the score, the patient may be very high risk, moderate risk, or low risk. If they're very high risk, then the patient ideally should not be fasting. Moderate risk patients are recommended to not fast, and low risk should be able to fast in most cases. So it's important that patients know what their inherent risk is. Glucose monitoring becomes very, very important. Some patients need to, they may not realize, but they need to know that checking the blood sugars or using their flash glucose monitoring device may not invalidate the Ramadan fast. So, eating is not allowed, but they can still check their blood sugars, and they should be checking throughout the daytime, even if they are not eating, so that they can prevent the risk of unexplained hypos or hypers. And depending on their risk, they could check once or twice if they are low or moderate risk. But if they're high risk, they should be checking many times throughout the day as well as during the night. What are the dietary tips that you should share with your patients? The most important thing is for them to know that they will eat low glycemic index, high fiber foods. So Ramadan is a time of religious fasting, but for a lot of people, it is also a time of feasting. And during feasting, there's a lot of sweets, high carbohydrate foods that are distributed. So it's important our patients know that they should try to incorporate low GI, high fiber foods, avoiding the sugary desserts, and making sure that during the night hours, they are hydrated really, really well. Exercise, rigorous exercise is generally not recommended, especially during summer months because of the risk for dehydration and potential risk of hypoglycemia. Medication adjustment. Patients on metformin can continue to take their metformin if they're taking it once a day, like Remus. They are asked to take it after the biggest meal of the day, and twice a day can be taken with the two big meals. If they are still on TZD agents, then it can be taken after iftar, which is the biggest meal at nighttime. If they're on short-acting glucagon ripaglinide kind of agents, then instead of 3 times a day, you make it only 2 times a day and base it on the meal size. So for the morning meal, take a smaller dose of the ripaglinide and a bigger dose with the evening meal. If the patient is on sulfonylurea therapy, just like our patient Reem is, it's really important to note that we should be trying to switch over to an alternate class if possible with a different class of agent without the risk of hypoglycemia. Wherever possible, try to avoid glyburide, which is an older sulfonylurea, and try to use gliclazide or glimepiride, as these agents have a lower risk of hypoglycemia. If they're taking once a day only, they can continue to take it with the biggest meal of the day. If they're taking twice a day, the nighttime dose stays the same, but the morning dose can be reduced. And again, older drugs should be avoided as much as possible in sulfonylureas. GLP-1 agents can be used as long as they are not introduced too soon just before Ramadan, because we don't want our patients to be significantly nauseated during Ramadan. So making sure that they have been on a stable dose and are doing well without any GI side effects for a few weeks before Ramadan sets in. DPP-4s can be continued without any modification. SGLT2s as well, because sometimes when patients start an SGLT2, in that initial period, they may have a slightly higher polyuria risk. So we want to make sure that they are started in ahead of time before Ramadan. And if needed, you can use a lower dose, but frankly, if patients are tolerating it well, it's okay to continue. It's recommended to take it in the evening meal and making sure patients are drinking plenty of water during Ramadan. Finally, if patients are on insulin, if they are on long-acting insulin, I would suggest reducing the dose by 15 to 30% and taking it at nighttime. If they're taking twice a day insulin, then clearly the morning dose needs to be, the morning dose that they would have taken previously should now be taken in the evening. And currently in the morning during Ramadan, they take half of the dose what they are intended to take. So that's the important thing. And short-acting insulin, obviously there's no lunch as such, so there won't be any lunchtime insulin. It can take the full dose at the night meal, but reduce the morning dose insulin by 25 to 50% so that we prevent the risk of daytime hypoglycemia. So coming back to our patient, she is classified as low risk type 2 diabetes, well controlled on a new generation sulfonylurea, so that's a low risk patient. She can continue, and it is okay for her to fast as long as she's checking her blood sugars. Personally, it is suggested because we want to switch her from the sulfonylurea, we switch her instead to low dose SGLT2 inhibitor, stop the DPP4. If needed, we can start a GLP-1. We still have plenty of time there, and making sure she's checking her blood sugars regularly. And most importantly, very, very crucial, is that after Ramadan, we meet with her, talk to her about what went well, what did not go well, so that we can develop a plan in her EMR chart. We document that plan for next year's Ramadan. We are well prepared. So with that, I'm going to leave the objective slide here on the screen for you to view, and I would invite our moderator back for the Q&A session.
Thank you very, oh, sorry, my video didn't come out. Okay, so thank you very much, Dr. Jane. That was a really, really excellent presentation. I have numerous questions are coming through. So the first question, and this is like a really, really relevant question, is that are there any studies on Latino populations where whether they behave more like Black populations, Caucasians, or even Asians, respect to the cardiovascular risk factors and treatment?
Yeah, so that's a really good question. There's plenty of American studies that looks at the Latino immigrant population, and again, there are inherent differences over there as well. So diet is a very crucial aspect. There can be more carbohydrate-based meals there. And then there's also a slightly higher risk of insulin resistance. So that becomes really important. In the American studies with the Latino population, it has been seen that they often find that access to healthcare is limited and language is often a big barrier. So I would anticipate very similar challenges here as well in Canada. So I think that, you know, again, it goes to the same, the overarching message is, you know, individualizing, looking at it from the patient's perspective and finding out what their challenges are so that we can better equip ourselves to deal with those challenges.
Yeah, no, that's a very good point. So, okay, so if the patient is already on diuretics and you want to add the SGLT2 on top of the diuretics, how would you manage the diuretic dose, especially if they are going to fast?
Yeah, that's a great question as well, very practical because we do know that SGLT2s are also osmotic diuretics. So they can cause the blood pressure to drop, and there's a little bit of that polyuria that may occur initially at the initiation stage. If a patient is, clinically they are volume overloaded, then I would add on the SGLT2 on top of the diuretic. It's important to note that SGLT2s cause volume depletion by reducing the fluid in the intravascular component, which is very important. Whereas, with the diuretics, they often are caused. Sorry, so my bad. The SGLT2s cause reduction in the extravascular component, which is where the fluid tends to accumulate, whereas diuretics can cause depletion in the intravascular component, making the patients very dry intravascularly. So that's one aspect. If the patient already has, blood pressure, their systolic blood pressure, say, is between 100 to 120, then I would stop their diuretic when I'm adding the SGLT2 inhibitor. If it's say between 120, 130 in that range, I would reduce the diuretic to half or drop it even. So the whole idea is we want to prevent volume depletion or dehydration. So especially with Ramadan coming up for these patients. So it's important that we can reduce or discontinue the diuretic for those patients.
Okay. Okay. Well, thank you very much for simplifying the complicated question. So, interesting question. So, there have been a notion that in a Black population, diuretics tends to work better in for hypertension than any other medication. So let's say you have a patient, Black patient coming in with a hypertension on diuretics and has been doing really well, and suddenly the patient gets diabetes, or you just find that the patient now has diabetes. So now, just given the fact that the patient, and let's say the whole renal function and everything is fine, would you then switch that, sorry, the diuretics to ACE or ARBs, or would you just continue with the diuretics?
Yeah, that's a really good question as well. Now, it's interesting because previously it was very, it was printed in medical textbooks that diuretics are the way to go for our Black patients. But now, especially, that is becoming quite controversial as well. So, depending on the, when you talk to experts and nephrologists, even for instance, they'll say that the data is not really too discrete. It's like different shades of gray there. The whole idea, again, is that we know ACE inhibitors and ARBs by far offer much better nephroprotection than diuretics do. So at least from that perspective, especially if the patient is meeting the Diabetes Canada guideline recommendations, which is if the patient has microalbuminuria, if they have retinopathy, or if they're over the age of 50, then it's important that these patients are started on an ACE inhibitor or ARB therapy. So I think that would take precedence over using a diuretic therapy just for the sake of
Yeah, no, great. So for the sake of time, I'll just take one more question. And would you ever allow the blood sugar to run high during Ramadan to avoid the hypoglycemia, given the fact that, I mean, it's only a 1 month event?
That's a really good question. And the short answer is perhaps I may. Because again, hypoglycemia is a very, very big concern. So we want to avoid hypoglycemia at all possible costs. Slightly higher blood sugars are permissible. The current guidelines do recommend that it's okay to have a slightly higher risk of hyperglycemia. But it's really important that we reevaluate these patients at the end of Ramadan because something clearly needs to be modified based on how the experience was, and whether it's dietary modification or perhaps using agents that do not cause hypoglycemia but can still cause glycemic control, that would be the optimum way to go.
Okay, great. So thank you so much, Dr. Jane. There was an excellent, excellent presentation as usual. So I'm sure we all have learned a lot. And I just want to mention about the implicit bias because I think that's such a huge, huge thing that we may not be aware of. I mean, there have been some pain studies done from US looking at the Black population where they say that there is a perceived notion that Black population patients actually feel less pain. So therefore, less medications are given. Dr. Ross here in Calgary makes an excellent point where he says, you know, we sometimes give or offer GLP-1 receptor agonists to people who bring their Gucci bags and very well dressed, whereas if the patient is not poorly dressed and they don't actually offer it, and meanwhile the patients are willing to go out of their way to buy the medications, and his comment is like, who are we to judge whether the patient can afford the medication or not? So I think it's really, really important that we have to offer and treat everybody the same, and even more so. So please, if they are in a minority population, so please, please, please do go and check out the Harvard implicit bias test. It's an excellent tool. I've tried it before, and it was really, really fascinating. So, so Dr. Jane, you highlighted that the Canada is a quite diverse population, and we have a huge diabetes prevalence, and it's getting worse each time. And there are many differences, I think, between each patient and how we can individualize the therapies, but making it more diverse population and different cultures bring things more interesting and more complicated, or complex maybe would be a better word, with some visible and some invisible barriers. And clinician focus may be different to patient's focus. I think that's such a important thing, because we really have to think from the patient's perspective, not from our perspective. You also highlighted the issues such as systemic racism, which is quite prevalent here, and biases, implicit and explicit biases, stigmatism, and so on. You also went over some of the key aspects of the three populations that we went over, and maybe perhaps we should start focusing and paying a bit more attention to the visible minority populations, given the data that we have. You also mentioned about the overweight in Asian population with the BMI starting over 23, and the cardiovascular risk in a white man with BMI of 30 is equivalent to Asians of 22 or 23, which is really interesting and scary at the same time, because I know my BMI is definitely over 22 or 23. I don't know if that's the reason I couldn't get into the K-pop group, but it is actually quite scary. And you also mentioned that the complications from diabetes is a lot more severe compared to the other population, which I think we should be mindful of. And I think we should also know that the Asians get the cardiovascular complications 10 years earlier as well. And thank you so much for simplifying the diabetes management during Ramadan and giving some insight to what's happening during Ramadan. So thank you, Dr. Jane. Please, to all the audiences, please don't forget to fill out the evaluation form, and which is on the chat box. So please do that. It's really quick. It's not very difficult. And then within a day or two, the certificate of attendance will be sent out as well. Finally, I would like to thank Janssen for sponsoring this event, and also to Salient Communication and Platform Production for making this possible as well. I hope this has been a useful session for all of you. Thank you so much once again for joining this session. Okay, hope you have a good evening.
Thanks. Take care, everyone.